Now let's move on to the discussion panel with the three people I alluded to earlier, Dr. Hitchon, Dr. Ye, as well as Linda Roy. So we did ask for some people to submit some questions that they would like answered. Some we will not address just because they cannot be addressed in this format. But one of the questions that we did receive, one of them was about warning signs. Are there warning signs that we should be talking to our doctors about bone health? I'm not sure if Dr. Ye or Dr. Hitchon can address that.
Sure, I can start with this. The interesting thing about having osteoporosis is that you really don't have symptoms of it until you break a bone. And so, in terms of identifying people who are at risk of having osteoporosis or who are at risk of having fractures, it's really about your full picture of, medical conditions, your fall risk, medications you're on. So, it's not so much about warning signs or symptoms, but more about just all the things that make up your health and that really needs to be addressed by you and your clinician in terms of going through those risk factors.
And so looking at risk patients, Dr. Hitchon, can you talk a little bit about who would make a patient at risk for bone health problems?
Certainly. So from a rheumatology point of view, in addition to what Dr. Yi has already mentioned, when looking for someone who's at higher risk for symptomatic osteoporosis, symptomatic meaning risk of fracture, certainly there's a number of risk factors in terms of general health habits. So certain things like smoking or uh, taking excess alcohol can increase and affect bone health. Certain medications, in particular for rheumatology, corticosteroids, can certainly affect bone health. And anyone who is a little unstable and has risk factors for falling, that will also increase the risk of concerns of fracture. Family history can be important as well. And if you have a family member, a parent who has had a significant fracture, like a hip fracture, that can increase your risk of having poor bone health. In the clinic, when clinicians or rheumatologists think about screening for osteoporosis, we ask many of these questions or we assess many of these risk factors. And then there are some clinical things that can kind of give us an idea that there may be some concerns with bone health, and that being change in height over time. So when you come to your doctor, oftentimes you get both your height and weight measured. And monitoring the height over time, if it starts to decline without other reasons, can be a sign that there may be some concerns with the bone health. Also, with bone health, sometimes it can affect the bones of the chest area of the upper back, and that can cause you to bend forward a little bit. And if you find that you're leaning forward more, that can also be a sign that there may be some concerns of your bone health. So in the clinic, your doctor will likely look at all of these factors, both your health, your medication, your family history, your health and habits, plus some basic clinical measures to assess what the risk is of osteoporosis and then or poor bone health, and then can take measures to address and intervene on those risks.
Thank you, Drs. Ye and Dr. Hitchon, about that issue. One of the things that came up in Kaira Naidu's presentation was overlap symptoms, the brain fog and the fatigue and the joint pain. Dr. Hitchon, what challenges does that present for you as a clinician when you get a patient that reports those symptoms?
The symptoms of bone fog and fatigue and hot flashes and those can be symptoms of both rheumatic disease as well as menopause. And it can be very challenging to distinguish what the source of those symptoms are. And it basically requires careful thought and evaluating other aspects of the rheumatic condition to see if there's other suggestions that the rheumatic disease may be more active, and maybe even supporting that with some investigations. But it is very challenging for sure.
The other question that we received was about early onset menopause, and that may touch on the one who asked about cancer treatments. How does early onset menopause, does that affect or impact bone health?
I can start with this one. Yeah, early menopause definitely can impact your bones. As we go through sort of our lifespan, you increase your bone mass until about age 25 to 30, and then you maintain that pretty steadily for both men and women until women hit menopause. And whatever age that is, that's when you get a much more rapid decline in your bone density. So we're averaging about 8% bone loss over the whole perimenopausal menopausal period. And then after menopause is done, you start losing bone at a rate of about 0.5% a year after that. For men, they don't go through that rapid drop, but in around age 60, 70, they start having that steady decline as well. So if you're going through that decline earlier, you're starting that bone loss earlier in your life, and your fracture risk will go up subsequently.
Thank you. That's helpful. And I'd like to bring in Linda Roy and your experience. You have a rheumatic condition and your experience with your own bone health. Can you enlighten us, Linda?
Well, at onset with my rheumatoid 30 some years ago, I was given steroids to sustain my disease at the beginning. And I was on prednisone for quite some time. But at the same time, I was given bone supplements. I believe the first one was Fosamax. And then after about 15 years, they put me on alendronate. Because I'd always been an athlete, my body was always, my bone structure was always very good. And the disease started taking over. And that's when my left knee became completely bone on bone. And I'd had to have weight loss surgery before they could do my knee replacement. But before that happened, it took almost 10 years from the time the knee had gone to the time that the weight loss surgery occurred. And then the knee replacement was done. So my shin was always very painful below my knee on my left leg. And when my surgeon did my knee replacement, he'd said that my knee was the worst that he had ever seen. But I'd always maintained calcium, magnesium, vitamin D, and that was always very important in my journey, as well as good eating habits. I'd always eaten as clean as I could. Sweets are my downfall, but I'd always tried to keep my body going as well as I could in my lifetime.
Sounds like a very frustrating process that you've been through, Linda. And that brings up some of the things you brought up, supplements, you brought up lifestyle. And one of the questions we did receive was to preserve bone health in menopause, we are encouraged to do weights and to do impact exercises. How do we do that, especially when we're not feeling up to doing those things? How can we maintain good bone health, bearing those limitations in mind?
For myself, once I was able to start walking again, because that's been a thing throughout my journey, I was 500 pounds when I arrived in New Brunswick. My disease was completely out of control, and just having the best support, I found the best medical group in my region here. They've all listened to me. We talk to each other. We bounce everything off. My newest rheumatologist, he's new to the region, and he and I spent 3 hours on my first day with him, because I'd had 20 something years ahead of his journey at the same time. And we work one-on-one, like, and all of my doctors are like that. They will actually call each other during my appointments if they find that I'm in a crisis situation where they need. And I've had to relearn to walk many times in my life. I get cellulitis, I get tendon tears, and my right shoulder needs to be replaced, which is going to happen this year, finally after 6 years. So I'm one of those people that just keep going. They named me Cinderella at birth, and I tell you that glass slipper is I just keep digging for it. That's the way my life is, and my husband's my confidant, and he's there for me all the time. So, and so is my family.
That's
And I
wonderful, Linda.
appreciate having this opportunity. It's just my passion is my pill, as they say, for my chronic pain. So.
It's you highlight, Linda, the importance of having peer support, and I think that's important to have those discussions with other people that are affected, other patients, but also the communication between the doctors. Do the doctors, Hitchon or Ye, have any recommendations as to what we can do as patients in our lifestyles to maximize bone health?
So in our osteoporosis program, the Northern Alberta Osteoporosis Program, all the patients who come through before they see a bone health specialist one-on-one, they do a group class. And in the group class, we cover weight-bearing exercises, spine-sparing exercises, falls prevention, and so on. And I think what's important to highlight is both when you have osteoporosis and you're at risk of fracture, and also when you have a chronic health condition, including arthritis, it's really hard to do exercises safely without guidance. And I think it's important that if you're not sure if what you're doing is safe, you should see a specialist. And by specialist, I think the best people out there for that would be physiotherapists who can help guide safe exercise. And there's actually a certification program called Bone Fit that physiotherapists can take and then be certified in recommending exercises that are safe in osteoporosis. So for example, certain twisting or forward bending motions aren't the safest if you have really low bone density in your spine. So you can actually go and find Bone Fit certified physiotherapists across Canada if you just go on their website, put in your city. So that would be one recommendation in terms of guiding safe exercise. One little thing that I love sharing with patients is if you're already able to walk, if you can add in walking with poles, that's a great thing for your bone health, because walking is great weight bearing for your hips, but it's not great weight bearing for your spine. And unfortunately, in especially inflammatory arthritis patients like rheumatoid arthritis, your spine is usually the area that will have the lowest bone density. So in order to stimulate growth of bone in your spine, you want to actually load through it. So if you just get a pair of walking poles, every time you strike the ground, that little zing going through your arm actually zings through your spine. And there's been multiple studies that have shown that that can actually improve spine bone density. So that's a really simple little thing you could add into your routine that's actually safe, because it actually helps with balance.
And one thing I'd like to add, I actually never experienced menopause through this whole journey. I had to have a complete hysterectomy a few years ago because of cervical cancer. And that was just the way that went. And I think I'm getting the hot flashes now, though, but that could be then part of the rheumatoid. I do have night sweats quite a bad, but and I've never experienced anybody else that did not experience menopause. There was a lady in our group the other day that she had the same. So, yeah.
Interesting, Linda. That's really good to know, Dr. Ye, about the poles. I didn't realize that walking with poles would have that benefit. So that's a very simple thing that people can add to their walking routine, which I probably will do. Is there something with respect to diet or supplements or things of that nature that either Dr. Hitchon or Dr. Ye recommend to their patients?
the for diet, mainly a healthy diet is in terms of general approaches is important. For supplements, calcium and vitamin D are sort of the building blocks of bone. And particularly in individuals who are taking medications like steroids, it is an important adjunct to have adequate calcium and vitamin D. If you can get calcium in your diet, that's optimal. And so I always suggest that a dietary review, sort of review what you eat and what kind of calcium-rich foods you have in your diet and try and optimize those. It's much better than taking a supplement for a variety of reasons. And sometimes seeing a nutritionist or a dietitian can help with this. I know rheumatologists, or I'll speak for myself in general, are not specialists in dietary programs, but seeing a specialist who is can sometimes help you optimize calcium type foods. And there's a variety that can even be taken if you have lactose intolerance.
Thank you, Dr. Hitchon. That's helpful. Can either of you comment on medications that are given for bone health, and those more specifically with those with rheumatic conditions?
So the medications we use to treat osteoporosis really don't differ for those who have rheumatic conditions versus those who do. The only difference I would say is if you're on chronic steroids, there is some evidence that the bone building drugs called anabolics might be better at preventing bone loss while you're on long-term prednisone, for example. However, access to those drugs are pretty limited, so that's not necessarily realistic. That would kind of be the only major difference. I guess the other major difference would be some rheumatic diseases can cause kidney failure. And so if you have reduced kidney function, that also changes how we might prescribe the osteoporosis medications. But in general, osteoporosis medications are split into two big groups. There's the anti-resorptive, so that includes what you were on, Linda, Fosamax, Actonel, Aclasta, zoledronic acid, alendronate, risedronate. Some patients who have had breast cancer and are on aromatase inhibitors get another one called clodronate. So those are the main ones available in Canada. Those are the bisphosphonates. Another additional drug in that group called the anti-resorptives. These are the ones that prevent your bone-eating cells from working, is denosumab. That's the injection that's every 6 months. So that's one group of medications. They all work very well at preserving bone health and preventing fractures. There's a newer group of medications called the anabolic agents. These drugs target the bone building cells, so these actually increase bone density more than just maintaining it, which is what the other group of medications. There are two main ones in Canada called teriparatide and romosozumab. These medications are by injection and they're more expensive. They usually require you having failed some of the other medications before you can be covered for it. But at the end of the day, all of them work well and they've all been shown to prevent major osteoporotic fractures.
I recognize the medication that I'm being given is alendronate. That's the it's an infusion.
Yeah, that's probably zoledronic acid.
That's
It's
right.
similar to alendronate, yeah.
Okay. Are there any concerns about long-term use of these types of medications?
Yes, mostly the bisphosphonates. So again, alendronate, risedronate, etidronate, clodronate, zoledronic acid. These ones, they store up in your bones. So even though they're not in your bloodstream very long, when you stop taking it, for example, they're still in your bones for years. Oh, okay. I'm just seeing the comment here. So the concern with being on these medications too long is that there's a really rare side effect with this group of medications called atypical femur fractures. And that's where you can get a break in the biggest bone in your body, the femur. And sometimes that break can happen out of nowhere without even a fall. That risk is much, much, much smaller than the benefit and the fracture reduction from taking these medications. But in order to balance that risk with the benefit, after so many years of taking these medications, if it's safe to do so, depending on how your bone health is at the moment, you can benefit from taking a break from them. So taking a 1-year drug holiday will reduce that rare side effect by about 50%. Taking a 2-year drug holiday will reduce the risk of that rare side effect by about 80%. So that's the reason we don't take the bisphosphonates for too long. With the other medications, we don't do drug holidays.
Okay, that's helpful. I was wondering because I heard just when we were discussing doing this webinar about drug holidays or biphosphonate holidays, so I wasn't sure what that meant. Are there any special considerations for someone who is on these medications and who is facing surgery, for example?
If you are going for, the bottom line is no. There used to be some concerns that if you're getting orthopedic surgery, that if you're on some of these anti-resorptive medications, it can delay healing. And so that used to result in people who came in with hip fractures, which is a sign of osteoporosis, having their osteoporosis medications start delayed because people thought we should let them heal from their hip fracture and then start it. There's been enough studies to show that any effect is negligible. So you can continue on with your osteoporosis medication, and it's probably better just to start it right away. It can, some of these medications can affect your calcium levels, and so around the perioperative period, that just needs to be monitored. That would be the main thing.
There was a question that was submitted, and it was alluded to during Kaira's presentation, was the question about the concern about HRT, hormone replacement therapy, causing flares. Can either Dr. Hitchon or Dr. Ye comment on that?
So for HRT, which is basically hormonal therapy for treatment of menopausal symptoms, any increase in hormones or change in hormones does have the potential to affect rheumatic disease activity, but this really depends on which rheumatic disease you're referring to. There's less concern with flares of rheumatoid arthritis. It's important to remember that at the time of menopause, sometimes arthritis symptoms can get worse. The time of menopause can sometimes be a time when rheumatoid arthritis presents, and so changes in hormone levels may affect that. In general, though, if the arthritis is stable, it's not going to significantly worsen flares, but everybody is an individual. There are some concerns with other types of rheumatic disease with hormone replacement therapy, particularly some of the connective tissue diseases like lupus, in which case there are some features of lupus that really need to be considered before deciding on starting hormone replacement therapy. And these relate to the risks of certain complications of these conditions and how these risks may be heightened by the use of hormone replacement therapy. And so this is the discussion that really needs to be done in context with your rheumatologist because it will depend on your specific situation.
All right. Again, very important to speak to your clinician about your particular situation. Everyone's different. Medication affects people differently as well. So that's an important caveat. We have about 5 minutes left. I know that there was a final thought given to us, I believe, by Kaira about the importance of, the clinicians providing guidance and support. So I'd encourage you to read her final thoughts on that because it is very true and poignant. And if anyone else has any questions or you think of questions later on, you can always write to myself or Lori Prue, and we could endeavor to have those questions answered for you. I don't believe this will be the last webinar on this topic. There's a lot to talk about, a lot of discussions to be had. I don't know if Lori, if you have any final thoughts. Lori has included her email address, so that's great.
Yeah, no, I was just going to share that here. I'll share the QR code. Sorry, just trying to QR code to our survey just to give any feedback on this webinar, any addition, and just to give your thoughts on some of these topics. Generally, it's a 3-minute survey, so it won't take long, but just to better understand maybe what we could do to better support people living with arthritis around some of these topics, resources, for example, and that sort of thing. And so anyways, there's an English survey and a French as well. So I just encourage you to share your thoughts. And I put the link in the chat, the QR code. So if you want to just use your phone, you're more than welcome as well. And yeah, just I think it is an important topic, and it would be nice to hear from people in terms of what is something else that that we could do to better support folks. So I'll stop sharing now, and you can see the English and French links in the chat. And with that, Natalie, if you have any final words, yeah, you're more than welcome.
No, I'm just very thankful for Dr. Hitchon, Kaira Naidu, Linda Roy for your time, Dr. Ye. It's been very informative. I think it's important to keep that conversation going. So I'm encouraged, and hopefully we'll see each other in another context in the future.
Thank you so much for hosting this. Menopause, among a lot of things out there, we have to stop making it almost like a joke. Do you know what I mean? Like people, but it's not. It's a really serious thing that impacts so many people's lives in so many ways. And the more we talk about it, the more we help normalize and make it okay to talk about it. And this is such an important first step. So thank you, thank you, thank
I
you.
wonder if it would be talked about more if males experience this.
Yes, of course. I think
You
that
got
may
you gotta wonder, right?
yeah, maybe a subject for another time. We'll get more men involved in the
Mhm.
discussion.
Yeah, I know,
Yeah,
for sure.
I know
All
this
right.
man here.
Yeah. No, absolutely. Yeah, and many thanks, yeah, for everyone for your active participation, to Natalie as well for, moderating this discussion, and Linda for being so open with sharing your experiences, and Carol, Carrie, and Kaira for sharing your expertise in the area. I think we often don't always get a lot of time to talk about these things in depth, with our rheumatologists in clinic, or our family physicians or others. So it's just really nice to have an opportunity to access that sort of expertise well, and put it in context of people's real lived realities, as Linda has and Natalie have really emphasized here. So yeah, I
Thank
just
you,
think,
Lori, for
thank you.
organizing it too.
No worries, no worries. Thanks all.
All right. So we'll see you next time, everyone.
Yeah.
Thanks for the
Bye-bye.
opportunity.
Hi, everyone.
No worries.
Take
Bye-bye.
care. Nice
Thank
meeting everyone.
you.
Take care.